Hi everyone. Now we are going to see about RH immunization and ABO incompatibility. My name is S. Ruth Kesia. I am working as a tutor in Triple M College of Nursing. First, we'll see about the definition. RH immunization is otherwise called as rhesus incompatibility, rhesus disease, RHD, hemolytic disease of the newborn. When the Rh negative mother gets pregnant to Rh positive fetus, she may be sensitized to Rh antigen and develop antibodies. These will cross the placenta and cause hemolysis of fetal red blood cells. The risk of sensitization after ABO incompatibility is only 2%. Immunization. Immunization is a process in which immune antibodies are produced in an individual in response to injection of antigens from another individual of the same species who possesses antigen that the first one lacks. Antibodies, Rh antibodies develop when Rh positive cells enter the circulation of Rh negative person. In obstetrics and gynecology, this happens due to feto-maternal hemorrhage during abortions, childbirth, rupture of ectopic pregnancy, antepartum hemorrhage, versions, and amniocentesis. So in all these cases, what happens? There is an exchange of blood between the fetus and the mother. Normally, there will not be any exchange of blood between the mother and the fetus. The blood used to pass from the mother to the fetus through the placental bed. But in this case, there is an direct transfer of blood to the fetus and the mother. Pathophysiology. Now we'll see about the pathophysiology. There is a transfer of fetal red blood cells. So the mother responds by producing antibodies against Rh factor. So after first exposure, that is usually delivery, begins after the exposure to the Rh factor from the fetus, the mother begins to show up in her serum after a few days. Since the production of Rh antibodies take time, so that is from the delivery, the first Rh incompatible fetus usually escapes the disease unless the mother has been sensitized earlier by an Rh incompatible blood transfusion or by abortion or by ectopic pregnancy or any kind of feto-maternal hemorrhage. The incompatibility of the ABO groups can occur more frequently than that caused by Rh factor. It usually occurs when the woman is type O and the fetus is A or B. The hemolytic disease due to ABO incompatibility can occur without prior sensitization. It means, for example, if the mother has blood group O and she is having antibodies for A and B even before she is getting pregnant. So the firstborn will be affected in this case. But however, the disease is much less severe with ABO isoimmunization. Now, let's just understand the pathophysiology from this diagram. So this is the fetal RBC. It means the fetal circulation, blood from the fetus. So through the placenta, it enters the mother's circulation, the mother's blood circulation. So the mother responses by, the first response is called primary response. So that is given from 6 weeks to 6 months. So she responds by producing IgM antibodies. So these IgM antibodies are cleared by the macrophages. From the macrophages, the IgM antibodies enters the plasma stem cells. So the IgM antibodies, again, it binds with the RBCs and enters the fetal circulation. So what is happening here? The RBC enters the mother's circulation and it comes back with the antibody attached to it. So what happens? The same RBC will destruct the other RBC. So RBC which is having antibodies will be destructed. So the final result will be more destruction of RBC and there will be fetal anemia. Now we'll see about the secondary response. I already told you there is the RBCs are attached with the antibodies. It means the RBCs are not normal. Only the few RBCs are left which are normal. So what happens if this few RBCs crosses the placenta and enters the mother's circulation? There is a secondary response. Now this happens after 6 months. The mother responds by producing IgG antibody. Okay, so this antibody is ingested again by the macrophages. From there it goes to the T helper cell. So this is the second level of immunity in the mother. Okay, and then it goes to the B cell and the mother produces anti-D antibodies. So when this enters the fetal circulation again, there will be still worse condition of fetal anemia. Now we'll see about the complications after the pathophysiology. RH antibodies. So this is the antibodies produced by the mother. So the RBCs in the fetal circulation is coated with the antibodies. These are not normal RBCs, they are coated with the antibodies. So this causes, the antibodies cause destruction of the fetal red blood cells. So that leads to fetal anemia and fetal hypoxia and stimulate the erythropoietin. Why there is stimulation of erythropoietin? Because the fetus needs blood, the baby needs blood and oxygen. So the baby's brain gives command to the erythropoietin to stimulate more production of RBCs. So it gives command to the extramedullary red cell synthesis. And there is hepatomegaly. Why there is hepatomegaly? Because the RBCs are going to be destroyed. It's going to be excreted into the from the bloodstream to into the urine by liver. So the liver does the function of excretion of the RBCs. Okay, so there is hepatomegaly because there is more production of the RBCs and more destruction of the RBCs also. So that causes hepatic cell failure and subsequently hyperproteinemia, increased intrahepatic pressure, portal hypertension, and which leads to ascites, edema, hypoxia, placental thickness, polyhydramnios, and pericardial effusion. Now we'll see about the complications of neonatal anemia. They are fetal hydrops in stillbirth, hepatosplenomegaly, neonatal jaundice, complications of neonatal kernicterus like lethargy, hypertonicity, hearing loss, cerebral palsy, and learning disability. This is the kernicterus. When the concentration of bilirubin in the newborn blood exceeds, that is in term fetus, when it exceeds 307 to 342 millikilomole per liter, it is called kernicterus. And in preterm fetus, when it exceeds from 153 to 205 millikilomole per liter, then it leads to kernicterus. Kernicterus means the bilirubin moves from blood to the brain tissues. That is, it crosses the blood-brain barrier and enters into the central nervous system. Jaundice is just the excess of bilirubin in the blood, but it has not crossed the blood-brain barrier. So this is the hydrops fetalis. Here what happened, I already told you that there is excess of production of RBCs and destruction of RBCs. There is a hepatosplenomegaly and increased portal hypertension, and it leads to ascites, edema, and hypoxia, fetal anemia, and at last death of the fetus. So this is about the pathophysiology and the complications of RH incompatibility. Now we'll see about the management. The aim of antenatal managements are to predict which pregnancy is at risk, to predict whether or not the fetus is severely affected, to correct anemia and reverse hydrops by intrauterine transfusion, to deliver the baby at the appropriate time, weighing the risk of prematurity against these of intrauterine transfusion. So recognition of pregnancy at risk. How we will recognize the pregnancy mother who are at risk? So we'll check the blood group and the RH factor for all the antenatal mothers, if the mother is going to be negative RH factor, that is A negative, B negative or O negative blood group, then we'll do the indirect Coombs test for the all negative blood group mothers. So if this indirect Coombs test is positive, so positive means what it indicates, the mother is negative blood group, some positive RH factor, that is A positive or B positive or O positive RH factor has entered the mother's circulation and she is exhibiting some abnormality in the indirect Coombs test. So if there is any abnormality, it is going to come as positive. So if the indirect Coombs test is positive, then you have to check for the father's RH factor. So if the father's RH factor is also positive, then we anticipate some, the fetus should to have the positive blood group. So then after that we have to do the serial maternal anti-D titer values. So the titer values will be done every 2 to 4 weeks. If the titer value is less than 1/16, then we can conclude the fetus is not at risk of developing any hepatosplenomegaly or any complications. So if the titer value is more than 16, then we have to, next step is calculating the severity of the condition. How you will predict the severity of the hemolysis? First is by asking the history of previous affected pregnancy, the levels of maternal hemolytic antibodies, amniocentesis, biophysical surveillance, fetal blood sampling. So if any of these conditions has been done before for the mother, then we can conclude that the mother was already exposed to the RH positive blood group and she is been sensitized now. The next step is amniocentesis. So this is usually carried out at 16 weeks of pregnancy. There's an excellent correlation between the amount of bilirubin in the amniotic fluid and the fetal hematocrit. So how much amount of bilirubin is circulating in the fetal circulation, we want to know. So I already told you the RBCs are produced and destroyed by the liver. So seeing the RBCs, the amount of RBCs, to check the RBCs in the fetal circulation directly is going to be much invasive procedure. But this amniotic fluid, from this it is like a mirror value of the blood. So with that we can find out the amount of unconjugated bilirubin from the blood. Conjugated bilirubin will be excreted through the urine. So we are not worried about the conjugated bilirubin. Only the unconjugated bilirubin will get accumulated in the blood and it causes jaundice for the fetus. So this amount of unconjugated bilirubin in the amniotic fluid will give the value, that is a picture of the fetus blood circulation condition. So this can be obtained by this is some settings in the scan probe, that is optical density deviation at 450 nanometer. So this can measure the amniotic fluid unconjugated bilirubin. So apart from amniocentesis, we can also do ultrasound detection of RH sensitization, that is a scan, that is a placental thickness and hepatic size. Fetal hydrops is easy to diagnose when finding one or more of the following, that is ascites, pleural effusion, pericardial effusion or skin edema. These can be found through ultrasound examination, and Doppler assessment of peak velocity of the fetal middle cerebral artery proved to be valuable in predicting fetal anemia. So the next diagnostic procedure is the cartocentesis. It means taking blood from the umbilical artery directly from the fetus and giving it for testing. The next diagnostic procedure is the percutaneous fetal blood sampling. This is the exact. This will give the exact picture of the fetal or blood studies. So from this we can calculate the RBCs and the amount of conjugate and unconjugate bilirubin. It means the blood is withdrawn from the placental bed, that is fetal side of the placenta. So till now we have seen about the invasive blood investigation procedure which are done for the RH incompatibility. Now we'll see about the management. First is the direct fetal intravascular transfusion. Here The same way like the blood transfusion for the adult, we are transfusing the blood for the fetus which is in utero, which is inside the uterus, we are transfusing the blood. So the first management I told you, it is the blood transfusion. Now we'll see about the cesarean section. So when it is performed in the 34 to 35 weeks of pregnancy, because if the disease, the hemolytic disease is severe, we want to protect the baby, we want to take the baby alive. If the hydrops fetal is in any gestation, can cause antenatal fetal death. So we want to prevent the death of the baby. So in case of severe forms of hemolytic diseases, the baby will be delivered within 34 to 35 weeks of pregnancy by cesarean section. So if the hemolytic disease is in mild form, then we can go for the vaginal delivery and we can wait till term. So in second stage of labor, the main aim of labor, main aim is to decrease the fetal trauma. So we give the labor pudendal block and episiotomy to decrease the fetal trauma. In all other cases, pregnant women with the diagnosis of RH disease undergo delivery in the term of 37 to 38 weeks of gestation. The induction of labor is performed by prostaglandin in case of unripe cervix and by oxytocin infusion in case of ripe cervix. Next, we'll see about the prevention. So how we're going to prevent the RH incompatibility. First step is screening all the mother and identifying the RH negative mothers and placing them under high risk category. The next step is by administering anti-D immunoglobulin. If the fetus is RH positive, we give the anti-D immunoglobulin after the delivery or at 28 and 36 weeks of pregnancy. And also this anti-D immunoglobulin should be given after abortion, amniocentesis and placental abruption. So this is the anti-D immunoglobulin. It is called a ROGAM, RHOD immune globulin, and it is 0.3 milligram, and it will eradicate 15 ml of fetal red blood cells, and it should be given within 3 days after delivery. And if we suspect there is more fetal-maternal bleeding, either by placental abruption or antepartum hemorrhage, then we have to carry out the Claire-Bedke test, which is to estimate the amount of fetal red blood cells in the maternal circulation. And according to that value, we have to recalculate the anti-D immunoglobulin and administer the immunoglobulin for the mother. So this is about the management of the mother. Now how we are going to manage the fetus is if there is any mild anemia and that is hemoglobin is less than 14 grams per deciliter, cord bilirubin is greater than 4 milligram per deciliter, then we can give phototherapy for the baby so that the RBCs will get destructed. If there is a moderate to severe form of anemia, then we can go for the exchange transfusion after for the baby. And if there is mild hydrops, it will be improved in, it means there is some edema. Mild hydrops, it improves in 88% of the cases. But if there is severe hydrops, we anticipate the mortality to 39%. So till now we have seen about the uh, definition of RH incompatibility, the pathophysiology, the complications, the aims of antenatal care, diagnostic procedure, prevention of the any complications of RH incompatibility, and management in the mother and management for the fetus. I hope you all gain a little knowledge on RH incompatibility, RH isoimmunization, and ABO incompatibility. Thank you for your attention.